This is the Owens Recovery Science Podcast.
All right, welcome back to another Owens Recovery Science Podcast. This is Johnny Owens with Kyle Kimbrell. Wrapping up the end of the year, man. I'm trying to find a Christmas gift for you, Kyle. You're just so hard to buy for, dude.
I know. It's all right. I just bought yours the other day.
Some Rogaine to see if that might.
No, we're way past the Rogaine stage, buddy.
Oh, we're past it. Okay.
Yeah. No, we're full on. Telly Savalas, Mr. Clean over here. There's no need to intervene on the top of my face. At least, maybe the rest
we'll be
of
here
it.
Soon for the Owens Recovery Science annual Christmas party. So I'll just have a bunch of booze for you more than anything else.
That works. I was wondering what you were doing.
Yeah, drinking.
Perfect.
Throw a little bit of food in there.
Yeah.
Well, dude, this is going to be a badass podcast today because a
excited.
very, very good paper just came out from these folks. They're repeat offenders, have been on this podcast before. And we discussed some safety things that they were looking at, and what they are doing is, this is a landmark paper because this is a blood flow restriction clinical paper looking at its application in adolescents. And so I have Adam Weaver and I have Dylan Roman, both from Connecticut Children's. Just quick bios: Adam and Dylan, they're both physical therapists. They do clinical care. Adam runs the orthopedic research arm up there at Connecticut Children's, and so churning out some good stuff. And so it's cool that they're not only just in the research side, but also in the clinical side. And so I think their knowledge of seeing a gap that was needed helped bring them to looking at the application of blood flow restriction and post-op ACL adolescents. So without further ado, welcome, guys. Want to dive into this paper.
Thanks for having us, Johnny. Happy to be here.
Thanks, Johnny. Thanks, Kyle.
Yeah, man.
So
nice to have you.
Just to recap, you guys put out an initial paper early on because no one had looked at blood flow restriction in a clinical adolescent population. And so the first thing you guys did, which I love, is you kind of looked at the safety piece. And so can y'all recap a little bit for folks that might not have seen that or heard the podcast of what that paper was?
Yeah, so we published that paper in 2022, and we basically just took all of the treatment sessions that were part of our clinical trial, and we just did some frequency work. So there were about 500 patient sessions, and as part of each of our visits with our patients in the trial, we just recorded basically anything that was defined in prior literature as an adverse event. And so that's open for interpretation, but the premise of it really was to sort of look at DVT, nerve injury, which has been reported before. And then we defined minor adverse events, which basically was, could they tolerate it? Meaning, did they have to stop? And any other sort of adverse events that they had. And so the long and short of it was they tolerated it pretty well. And about 80 to 90% of those patients, more or less finished all of the sessions and reps in your normal treatment session. And then we had a small subset of patients that had some dizziness, itching, which was more sort of a histamine response. And we had a couple of patients that sort of repeated some fainting with that. So was received pretty well. So we were happy to get that out.
True. So a true like syncope fainting event, or almost like just feeling lightheaded and they felt like they were going to faint?
More just a lightheaded fainting, kind of like your patient that had not eaten and sort of had to stop from there, particularly on the harder exercises. But that was pretty rare. I think some of it we probably learned as we went, just sort of our dosing of how much weight to be using, so it probably helped with that. We were going too hard out of the gates, probably.
Yeah.
I feel like that's been pretty consistent in my practice too, where if someone has that kind of an episode, I almost always feel like they're dehydrated or they haven't eaten, like they didn't come prepared to exercise intensely. So could certainly be a dosing piece in there too, I would think, though. So it's a good point.
Yeah, nothing abnormal compared to like our normal exercise prescription and the side effects you see. The comment I'll make on it as we continued through this trial and we saw more and more exposures, still no significant adverse events or any of the big scary red flags. So it was overall, that paper was great to get out there, and then we saw the same trend going forward, that it was tolerated really well, and then overall really safe for these adolescent patients.
Yeah. So getting into now, can you guys, you put that one out, great. That was fantastic to see. And now move into this actual clinical trial. You guys wanted to describe your study design and your thoughts on moving forward with this?
Yeah, sure.
Sure, yeah.
Yeah. So this obviously Adam's kind of brainchild here is the PI on the project, and set it up really well for us, our first clinical trial here. And again, shout out to you guys after you kind of came in and trained our staff on our blood flow restriction training. We realized there's just such a big gap for this age group. We kept asking you these questions. Zach came and kind of educated us, and we kept saying, "Oh, well, what about in kids? What about in young adults?" And he said, "Well, I don't know yet. Why don't you guys do something about it?" So that's really kind of where it started. Yeah, but it was good. We kind of spanned over COVID. So we originally had a prospective arm and for an intervention group and a control group. The paper is, our intervention group. We ended up comparing to a retrospective control group, just because we kind of lost a good amount of follow-up for our control group throughout the kind of COVID pandemic. Started 2019, right before the world kind of crashed down. So that's why we had our prospective intervention group, and then a retrospective control group, which is kind of from our database. But the nuts and bolts of it, we had a 12-week intervention of BFR, and it was twice a week. And you had 3 exercises throughout the routine physical therapy session. And in the paper, we kind of laid out the exercise in a pretty stepwise progression, how we would, normally treat it in the clinic. Progressing load appropriately, patient dependent on their response and their perceived exertion. And then we tested some outcomes. We tested outcomes at their 12-week visit. We were looking at knee strength, and we were looking at functional outcomes based on the PD-IKDC score. And then we again tested kind of longer term outcomes at their return to play tests, kind of between that 7 and 9 month mark. And then we did similar isometric and isokinetic knee strength, and again the PD-IKDC scores. So it was good. We had the first clinical trial, also the early short-term kind of outcomes, as well as the longer-term outcomes to compare.
Yeah, that's fantastic. And I guess get into the nitty-gritty of this. You guys, it's always difficult estimating, a 1RM after surgery, and so you guys did use the OmniRes. Can you describe that? That's something we teach, but I'm not sure if everyone's really understands what that is or how you would apply it in these populations.
Yeah, so obviously the goal was, starting somewhere between 20 and 30% of their 1RM as a base weight. And some of these exercises, especially if you look at when we started BFR for these patients, it was really early post-op. So, about within the first week, about a week post-op for these patients.
Yeah.
So we didn't hit maybe their exact prescription always, especially early on, especially when you're starting with a quad set or a side lying hip abduction. But as we kind of progress through the program and you're starting to do some of the, long arc quads or split squats or single leg, shuttle leg press, we're definitely getting this OmniRes, basically kind of a variant of the, 0 through 10 RPE scale, and using that to kind of calculate if we should progress weight or kind of stay the same.
Yeah, you asked them basically to shoot for a 2 or 3, right, on that RPE scale, and that's their target load.
Yeah, so especially kind of scaling it before and then also after the exercise, seeing what their end RPE kind of came, and we use that to kind of leave a note for the next session if we're starting at the same weight or starting a little higher.
Right. And your LOP started at 80, and then you did it the way I like it: start high and then go down. I don't like to start low and then go up, because then they're like, yeah, I like the low. So basically that was it, right? Started at 80, and if they couldn't take it down and call them a wuss.
Yeah, we didn't cut any corners, even if they were younger patients. So we went as low as 12 years old for some of our patients.
Yeah.
And yeah, we pumped it up 80% LOP from the start. Obviously, if people were complaining of extreme discomfort, that's when we were able to kind of stepwise progression drop it down, as long as we didn't go below 60. But shockingly, a lot of people were totally fine with 80 when we applied the cuff appropriately proximal as high as possible. We use the contour sleeve underneath. So overall, most people stayed right at 80 for that.
Yeah. And 3 exercises per session. So that's a pretty good, a little amount of work on these kiddos. And
yeah, I was going to say, Johnny, we chose 80 initially, somewhat out of, kind of like, oh, that's what we were taught. And so when we did start, I think some of the initial, when we look at some of our tolerance data earlier on, was they were not tolerating as much. And I think that's probably a piece of it too, is that we weren't reading the patient well enough to know if they could tolerate 80. But I would say by and large, and even clinically now, I would say the majority of our patients, we don't really have to adjust the occlusion very much, except for the ones that sort of learn how to use the device, as they get going on, especially with some of our older college athletes. I've found that once they know they can adjust the occlusion, we'll come back and the occlusion's adjusted down. But for the purposes of this trial, we found that most of them, we did not have to adjust it very much.
I had a guy one time that would try and unplug it when I was gone and then come back over, and he didn't realize like an alarm would start going off. Freaking losers, they'll try anything.
You like a button that you push down, but it's a dummy button that it says it goes down, but it doesn't actually go down.
Yeah.
Just see if that matters really. Yeah.
And so the youngest was 12, right? And they tolerated this. That's awesome. I don't know how you've done. You can get a 12-year-old to do it. Like my daughters are like 14 and 16, and they can't even do BFR. They're so weak.
I would say definitely patient dependent, but we reported on kind of the sport activity level between our groups too. A lot of these were athletes, whether it was middle school, high school. So we were definitely lucky to deal with very motivated people to get back after this ACL injury. So I'm sure age isn't going to be the same across every diagnosis or patient population, but most of these kids were super motivated.
And these are all quad tendon repairs, right? No hamstring, and no concomitant lesions or meniscus repairs or anything like that. Just a straight up ACL. If Lord help you that you all actually could find just a isolated ACL tears, that probably really crushed enrollment as well. Especially in this population.
We had about half of the patients had a meniscus repair, but the majority of them did not have anything, and then we made sure that they were primary, sort of first time no revisions, contralaterals. And we picked 12 mostly just because that's really the beginning stage of adolescence, and so that'll kind of be some other questions we'll look to in the future, sort of stratifying by age a little bit more, just because we know sometimes the exercise response in younger ages is pre-puberty, or as they're hitting puberty, it can sometimes be a little bit different than sort of your 17, 18-year-old, older athlete.
Have you guys done it clinically on prepubescent?
The 12 is probably youngest for me. I don't know about Dylan. I would say most of our staff probably goes around 12. And I think sometimes it's more of a tolerance thing. It's hard to get a 9 or 10-year-old to understand their right and their left foot, much less, we're going to put this thing on your leg and you need to just figure it out. So we've done it. I would say probably some of our staff has. I haven't done much. I'm younger than 12.
Yeah, I've definitely tried it on 10 and 11-year-olds as well, but there's just such a spectrum in maturity levels and readiness at that age. But we get referrals sometimes, kids after a forearm fracture or like a tibial fracture, and they're in a cast. And even those patients where there's not a lot of other things we can do, and we still kind of think BFR is something really appropriate at that standpoint. So if that's kind of the main treatment goal right there, I have no problem kind of even starting the LOP a little lower and giving it a go.
Sweet. So going into your outcomes and then getting back onto the study here. So you look at knee extension and flexion torque isometrically and isokinetically at 3 months, and then at the return to sport. So again, that intermediate term, and then more of a long term. their limb symmetry index, the PD-IKDC. And that's basically it. So can you guys get into the details of what you guys found?
Yeah, sure. I can talk through that. If you compare kind of the raw data that we reported in the paper, obviously the BFR group was significantly stronger, both at the 3-month mark and at the return to sport mark. So we recorded it in peak torque, obviously how much peak torque you can isometrically kind of kick out. And we also looked at symmetry. So the interesting part, the kids with their involved leg, the BFR group was stronger compared to the control group, but we didn't see a really big difference in symmetry just because the BFR group, they got on their involved leg and their contralateral leg, we saw strength increases on both sides. So you look at our symmetry index, it's really nothing too substantial there. And obviously we're not upset that their contralateral limb got stronger as well. So that was kind of an interesting finding there that we saw kind of both at the 3-month and return to sport time point.
Yeah, that's fantastic. And that's something that gets ignored lots of times with rehab is, you're not looking at doing anything on a contralateral leg and it is actually significantly weaker, or you're comparing the LSI to a weak contralateral leg as well and thinking that you're within the kind of like safe range. So that was pretty cool. You guys did a great job in the paper describing that.
Great. Yeah, some bigger takeaways just looking at like the absolute peak torque, even early on at 3 months, it was like 1.8 Newton meters per kilogram in the BFR group versus 1.44 Newton meters per kilogram. So if you have, 0.4 Newton meters per kilogram increase at that time point, like that's clinically a really big increase for what we normally see around here. So, it makes sense that these kids ended up reporting better function as well, because that's definitely a higher increase than we were expecting.
And then on your self-reported, your IKDC, that was improved as well.
Yeah, yep. So that was improved at 3 months and return to sport. And then with our mixed methods, ANOVA, what we saw, that was it got obviously better from 3 months to return to sport. That was the same for all of our outcomes. It was higher in the BFR group, kind of at both time points. Then it got better faster in the BFR time point, in the BFR group as well. So yeah, definitely that was one of our main outcomes, because our surgeons like to see what the IKDC score is, and insurance companies do as well. So, that kind of closed the loop there.
Surgeons care about that? I didn't think they gave a rat's ass about anything, but the bone and how does the muscle look, and cool, you're cleared to play. Did y'all track return to sport time frames at all? I mean, I know it wasn't published, but was there any trend you guys saw in this, or that you're seeing clinically, and maybe actually going back to sport, but meeting the return to sport criteria? The Methodist guys in their ACL paper, not in adolescents, they got about a 6-week kind of improved return to sport time.
Yeah, that wasn't one thing that we actually tracked, especially with our kind of standard practice here at Connecticut Children's. Everyone's waiting until 9 months for these kids regardless. So they have kind of a 9-month follow-up where, the majority of ones that don't undergo complications are usually getting some sort of sport clearance at that time point. So that wasn't something we tracked for now.
Yeah, good. Well, you hate to hear they met criteria and we sent them back to sport at 6 months, because as of now, unless something changes, let's please not do that. So fantastic. How about surgeon buy-in? Did you guys have any issues? I mean, I know you guys have been doing it here, but most of the surgeons, as well as like parent buy-in, any pearls you guys would give people treating adolescents?
I would say it seems to be, I would say our surgeons have always been pretty supportive of any of our ideas. I think, I think we've said this in the past too, and just there's pretty good literature, to support the use of this at this point. The skeptics usually are on sort of how does this impact an open growth plate? How does this impact healing? And I think we're going mostly somewhat on conjecture and sort of theory at this point, and we probably don't fully know. But it seems to be as we've gone on, and sort of our other institutions that are children's hospitals, they're all pretty much on board at this point with, especially in this population, using it. And so, and parents, we were surprised initially. We thought we might have a little bit more, I wouldn't even say pushback, but we really got, we just explained what we were doing, and they're like, okay. And then they were kind of back onto, and the kids were usually okay with it too. So generally it seems to be okay. And I think people, this second trial around, we've actually had a few that we've had to exclude because we've had parents that said, yeah, my other kid had a surgery, or I had a surgery, and I want to make sure my kid has BFR as part of rehab. So, which has been a challenge we didn't think we would run into. So,
yeah, we tried to do a chronic weakness trial with post-op ACLs, kind of like the Noyes study, and we could not get our controls to stick to the control group. So that one went nowhere with us as well. So
that was wasn't that the issue too with the Pac-12 ACL trial?
Yeah,
couldn't get some of the schools to agree to have their football players included in the potential control.
Yeah,
really.
or the surgeon
ACL trial.
I know. Single arm study.
Yeah.
And I think you guys pointed out as well, you did everything like so perfect because it's super standardizable. Like this is LOP is a 60 to 80% range. You're basically trying to target that 20 to 30% RM through an RPE scale, which is pretty much all you can do in these post-op populations. And then your protocol. I love the way you did your ACL protocol. For one, you included a long arc quad, which is fantastic. And we don't have to get into that debate here, but it's something that these ACL patients really need. And you kept that long arc quad going, so you guys did this in blocks, a couple week blocks, it looks like on the protocol, but you did keep that long arc quad going and several of those blocks there just to focus on quad strength. So very, very easy for people to apply. And progressed into multi-joints, into closed chain. And the fatal flaw that some studies have been published have done, you increase load. I mean, these studies where it's like, we did 12 weeks and never changed the load. Like, really, it's crazy you didn't get results.
Yeah, we tried to take everything into account, and even with what we did, I think we still sort of learned some of the challenges. One of my takeaways was more that maybe just to really, from a research standpoint, simplifying our exercises even further, just to further bias quad strength, may be more beneficial. And that's kind of how we're moving in the, sort of we've moved forward, because we did see changes in hamstring strength as well. But if we really want to impact the quad, and we know that it's such a problem in these patients, that's kind of how my practice has changed clinically, is that I'm targeting it even more specifically with BFR, rather than trying to get cute with lots of different exercises.
Yeah,
really just picking 2 or 3 of the best bang for your buck and being done, and then moving on to other stuff.
Yeah, I agree. People like give up on it
inside right now.
Yeah. This is you're speaking our language.
All kind of happy feelings inside right now, Adam. Thank you so much for saying all of that.
Happy holidays.
Happy holidays.
Well, like there's no reason you can do long arc quads for 6 to 8 weeks or even longer, and it's almost like, well, we did it for 2 weeks, let's quit. And you would never like go to the gym and be like, I'm going to do bicep curls for 2 weeks and I'm stopping and I'm going to do whatever, some crazy little party trick bicep thing.
Yeah. I was just going to say, when we've also sort of seen that when we started this trial, we had pretty good experience with quad tendon ACLs, but the more that we've treated them, and I think the more that we see published, is they do sort of progress from a strength standpoint a little bit differently. And I think some of that has to do with the graft prep on it, as well as it being taken from the rectus femoris. So the changes in quad strength and sort of how they progress initially seems to be a little bit different, just anecdotally what we're seeing. So I think for us and for myself, it's made it even more imperative that really sort of providing consistent stimulus to the quad in multiple positions in a simple way. And even then, it still seems like that may not be enough in the short term, and we need to do it longer. We need to be providing a specific stimulus in an open chain position for a much longer period of time.
Yeah.
Have you guys tried like in varied degrees of like hip extension? Have you been playing around with that on your end?
Yeah, I mean, not so much with BFR, but certainly in just as we progress, whether
Yeah.
it's sort of leaning back in a semi-reclined or semi-reclined position, or even,
Yeah.
supine, we've been trying to, at least I have been, experiment with that quite a bit.
Yeah.
Yeah,
Yeah,
Kyle,
Kyle's
especially
all
with,
onto that. He clued me into it, and now I can't find anywhere I can fricking do it, like lay down, because I've got a leg extension machine. I'm all like hunched over the back of it, trying to get
Yeah.
as much hip extension as I can. So
yeah, I would say strength wise, and then even there, later on, depending on how we're loading it, we're seeing some of the kind of quad tendinopathy, tendonitis, and doing some isometrics and as much hip extension we saw. That's probably been one of our biggest interventions to clear that up a little bit.
Yeah.
Yeah, one thing jumping back to where Adam said, I think this trial definitely changed kind of our practice moving forward, where the results we saw, pretty great hamstring strength in these groups, and then we even presented last year at CSM. We also collected hip extension isometric strength at 3 months, and there was just no difference. Everyone's kind of hitting the criteria pretty good. So we kind of looked at our exercise program where we're given a lot of open chain hip. We're given some like double leg bridge exercises. So like, yeah, maybe it's not surprising these quad tendons, have no deficits there, but we're really still struggling on quads, even though they're better than control group. So I think clinically we've definitely shifted more towards let's be specific and intentional with our open chain quad and our stim application with BFR. So yeah, I think it's been good to change our practice.
And humble enough to look at this stuff and go, maybe there's some things we could change. Like I think that's the freaking downfall of so many clinicians is just a lack of freaking humility to look in the damn mirror and go, maybe I'm not the best effing PT out there, maybe I could improve a little bit. So kudos to y'all. I just love hearing that when people have like looked back at their practice and gone, okay, well, that didn't work, kind of got to try something else. So I love it, man. I'm all happy down here in SoCal.
I never had to
right
go
now.
through that, Kyle. It's weird.
Okay, all right, here we go.
I was gonna say I'm trying to humble Adam as often as I can. So
I remember I actually always tell this story about how the exercise phys propeller heads came through the CFI, Johnny. Like you used to tell that story how they came through and they're like, hey, what's that guy doing on the table where he's like raising his leg up? What is that? And Johnny's like, he's at an ACL. He's getting his quad stronger. And the exercise phys propeller head's like, yeah, no. Just like very matter of fact. Yeah, hey. That's
so he's doing range of motion, I think is what he said.
Yeah.
No, he's got a 3-pound weight, dude.
Like imagine the exercise phys, like professors are there to watch rehab exercise.
Yeah, it's embarrassing.
I'd be nervous, even knowing what I know now.
Everything.
Yeah.
So, I mean, obviously, this was like pretty much everything you wanted to see changed positively. So, has this helped with buy-in, where this is basically Connecticut Children's is saying this is going to be part of our protocol now, that you will do BFR after ACL?
Yeah, we don't really give them much of a choice unless they refuse, I guess, at this point. I mean, they always have a choice, but we sort of introduce it's kind of, and I think we've gotten some buy-in from some of our other clinicians that were a little bit more skeptical or hesitant, and so I think we generally will present it with most of our lower extremity knee patients, and unless they really just cannot handle it or tolerate it, it's going to be a piece of the puzzle. And I think where we're at now is trying to really determine, clinically, but I would like to move forward this way in the future, but of what's the optimal, when is enough, and how do we determine with that? Because no matter how many ways we sort of look into quad strength, at least if at these different time points, there's still an issue for the vast majority of these patients. There's still a quad deficit of some capacity. And so kind of like we said before, the more that we know, the more questions we have, like, why is it consistent? Why do we consistently see these 20 and 30% deficits? And there's things that are out of our control, but also, this is, so we're continually trying to figure out, ways to Band-Aid that or sort of bring it back up to par. And so,
And there may be things that are out of your control, like in talking with Eric Maida a lot, he's always really kind of on the side of, I think that joint is just kind of unhappy for a while. And you get to that 4-month point and things level off, and he really thinks it's just the joint kind of still settling down. And I kind of go, well, it seems like PFR would be kind of a nice intervention if you still have sort of a joint problem in that phase too. But I just love, like, let's see what we can do to figure that out. One of my kind of curiosities on you guys is, are you using neuromuscular stem with BFR at all in your ACL rehab? Is that something y'all?
Yeah, that's what Dylan said, I think.
So we don't,
Sorry, Dylan.
Not necessarily standardizing. I think our clinic, we've just definitely been pushing stim more and more. The more we learn about it, the more we see like some quad deficits persist. Clinically, I put stim on. I will gladly put, stim and ramp it up and, put a BFR on top of it. If we're kind of early on just doing quad sets or doing long arcs. More so just kind of in that one joint, not so much with like big functional movements or anything like that. Just trying super concise and isolated, but we stim as much as we can.
We tried to we put that initially in the protocol in the first 2 weeks for this study, for this this paper, and some of the challenges were just, one is time, and two, we sort of found like once they were moving and feeling a little bit better, we were just getting them doing quad sets, and then we'd have them do stim at the end. But I would say for all of us, from a stim standpoint, everybody has, most of our clinicians, and I can only speak for myself, but I'm moving towards doing stim upwards of 8 to 12 weeks now, and sometimes longer, and making sure, trying to get as many patients as we can to get a home unit, just because it's not enough. And the more that we sort of learn about just sort of, quadriceps inhibition, to me, that's just it's the one thing we can control, as far as an intervention. And so we try to do that and then do it in different ways, as we progress from there.
It's in our DOD protocol, our ACL protocol. So the first 4 weeks, it's just, you have to do it. Because our research coordinators are like, why are we still doing stim? It's like week 3. Just keep doing it and turn it up higher, please.
Yeah, we so now the way we ended up doing it is we early on we may do some of our BFR stuff, or any of our sort of manual therapy stuff and sort of basic function stuff, and then they finish with that. And then as we get going, that is always, we just finish with it, and then they'll be doing isometrics off the edge of the table with stim, and that's just how because it just takes setup, and we don't
right.
And then once we test them at 3, and if they're getting close to that, if they're close to that 70-80% LSI range at 3, which rarely happens, it seems like, then we think about dialing back on it.
I just made Lynn Snyder Mackler happy.
Yeah.
That's what we're after.
Yeah. We're all after that.
The world is better with Smack Dive happy. That's how we would do it all the time. Is we would just do it like right at the end of the session, and because you set the stim up to run, we'd set the BFR to just inflate, deflate, 5 on, 1 off a lot of times, and there's somebody around to kind of jump in and adjust something for the patient if they needed it. But just stick them off the table and tie them off to the table leg and go.
You guys feel like you're seeing the analgesic benefits in the kids at all? Or is that?
Yeah, good question.
That's a good question. I think we haven't really sort of measured it in any way. We some of us have experimented a little bit with some of our apophysitis, or particularly like the Osgoods, or even the Sievers to some degree, or these non-responsive patellar tendon type pathologies, and we do see it has been sort of helpful in that, but we haven't really, at least I have not done it consistently enough to really see a measurable change, other than in session they'll come back and it's like, it did feel better for a couple of days. But I think that would be a really interesting area to sort of investigate, just to see how measurable the change is, because we know there's a big change. So
well, especially that population, all that anterior knee stuff can be just such a nightmare with them, that if you're getting quad and analgesia, that's kind of huge for them.
Yep.
What about other plans? You guys, you put the first ped study out there? Are you guys gonna be looking at more trials?
Yeah, so we started a follow-up trial to this. We just started enrolling a few months ago. So we're in the early stages of that. And basically we took what we learned from that first study and tried to make it a better protocol. So we simplified some of our exercises, like I mentioned. We made the time of the protocol 4 weeks shorter. So we did 8 weeks instead of 12. Mostly because we were finding that just by 8 weeks, we want to get these kids moving and doing more strength and conditioning exercises. And then we're going to measure strength at an earlier time point just to see if the pre-op to the 8-week change is really what I'm kind of interested in looking at and seeing, because we know we're going to see an atrophy there, but maybe this is a way to measure it really mitigates that loss. And then we'll still follow them out for a year to 2 years. So we're hopefully, and we're also randomized this. So we have a randomized, the control group is going to be in-house with us, and they're going to do the same exercises just with no cuff. So we couldn't really blind it, but so we really try to take the next step. But we're running into all the challenges that come with running a clinical trial and recruitment and enrollment. In the absence of funding. So if anyone out there wants to fund us, call me directly.
I like it.
Even with funding, it sucks, man.
It's still a challenge.
We pay these people and they don't come. Well, and re-tear would be very interesting if you're looking at these far enough out, because that is such a huge problem in adolescents.
Yeah, we haven't we've obviously we do try to track that with all of our patients, and we had a decent amount, sort of in that 20 to 30% range of our intervention group had a re-injury. We just don't know how do we measure that, if that being related to BFR itself, and so on one hand, it's like we know that 30% of those patients retore, so we had the number was consistent with our intervention group. But then in the back of your head, you always kind of wonder, all right, would this have been different or not different in the presence of or absence? So I just don't know how. It's another sort of question in the back of our minds of how do we measure that to sort of see that direct relationship. And again, there's so many factors to that, to re-injury, that it's hard to put our finger on one thing with that.
Very cool, man.
Yeah,
I wonder. Go ahead, Dylan.
I was going to add in the new trial that we're doing, obviously, to kind of refine our protocol and see, what are the best interventions to give at an earlier time point as well, of strength measurement, but also looking at like the tolerance aspect to it, and what in this younger population, what exercises or what limb occlusion pressure is maybe best for some kids. So that's just something that we've, originally just started kind of collaborating a couple other children's hospitals, Nicholas Children's Hospital of Atlanta, ourselves at Connecticut Children's, and then Texas Children's. We're kind of just brainstorming how we're all tracking that the same way, just so we can kind of eventually make sure we're on the same page with, what we're recording, making sure, we're all kind of checking the same boxes. So hopefully we can look at that, in the near future and give some quality recommendations on what these kids like best.
Dude, that's badass. I didn't know y'all were doing that with those guys.
That'd be cool.
Early stages, but talk to us next year.
Yeah. Well, y'all are all playing nice. That's good. You should maybe talk to the folks at Andrews in Dallas as well, because they're kind of following the same path that you guys are with this, and I know they like to track a lot of stuff. The more the better.
Great.
Come out with a position stand type paper. Yeah,
we also have Nick Giampachuzzi, who works with us. He's as part of PRISM, which is a pediatric research in sports medicine. We're presenting he will be presenting what we did some survey results of just practice patterns with the use of BFR amongst providers at children's hospitals. So he's going to be presenting that in February. So just to try to get a better understanding of how the intervention is being used. Is everybody using it the same? Which is probably not the case, but what can we do things to make, what is the best way to implement this, not only just with BFR, but just in PT in general. So
is that at the PRISM conference, Adam?
Yeah, that'll be in Anaheim, and we'll be out in Anaheim in the end of January. Yeah.
He'll be at CSM as well. So if you're up in Boston, he'll have a presentation in there with the survey results. So make sure to look out for that.
Nice. Very cool. Yeah. We'll be there for sure.
He's going to publish that?
You'll have to ask him.
Okay.
We hope so.
I'll text
put
him
it out there
now.
right now. Nick will be publishing his data that he's going.
Yeah.
Now he has to. It's in the ethos.
Yep.
I like that. The idea, Adam, you kind of alluded to earlier, just sort of figuring out when to sort of move on to more traditional kind of strength and conditioning things. I think there's a need for that, especially as we start using BFR more. Like, how do you figure out, hey, this joint is okay to kind of tolerate this stuff? Or are there good ways, for example, to maybe kind of like feather in strength and conditioning? I know one thing that I just started doing in our clinic was I'd mix in some sort of like body weight, heavy kind of movement, and then just kind of see how people were the following day. But then once I felt like their joint was okay, we'd almost go like a heavy Monday and then a BFR Wednesday or something like that, so that we were sort of not just going like, now we stop the BFR and we do the heavy, like that always kind of felt a little bit too much to me.
Yeah, I've moved to using, in the early phases when they're more limited by mobility, kind of really using table-based stuff or a shuttle when they've got good enough quad control, and then using, again, from a long arc quad position or open chain, just using that as their BFR. That's the last thing they'll do for the day, and then we do all of our other stuff, and then we may just keep that in there. But I agree, it's not necessarily a cold turkey, but we've sort of tried to, once they've got good range and they're walking normally, and we feel like we can start to add some load. I'm sort of moving that way faster with that, and just I think every intervention you learn, and as you progress through professionally, you get gung ho about it initially, and then when you realize when you're more proficient in it, when to not use it rather than to just carpet bomb everything. That's where we're trying to be. I think that's the next step now, is can we be more selective and direct with the patients that really need it.
And there's always a patient waiting on the cuff, so the faster you get them off it, the better. That's
right.
That's our problem. Well, this is fantastic, man. Thanks for coming on, you guys, and sharing that. It is out. It's publication now. It is in the Orthopedic Journal of Sports Medicine. And you guys,
we give the title. I don't think we actually gave the title, Johnny. We should probably give the title.
It is Early and Late Stage Benefits of BFR Training on Knee Strength in Adolescents After ACLR.
Great.
And there's like 10 authors on it.
Yeah.
Well,
journal. It's an orthopedic journal. Orthopedic Journal of Sports Medicine.
OJSM.
We'll put a link in our bio. It's open access, at least right now.
Is it still? Okay.
Yeah. Is it one of those temporary open access things? Do y'all know, or will it?
No, it'll be open access.
Nice.
Yep.
Love it.
So just so your paper, I was reading through it the other day before I went to go do something, and I had stapled it to another paper and I didn't realize it. And I flipped through like your abstract, and then I flipped to the methods, and I went to the methods of the other paper, and I was just like, what in the hell are these guys doing? I text Colin them. I'm like, I don't understand what, like they're using different devices, and they're like testing LOPs. And Colin's like, really? So anyway.
Yeah, that wasn't us.
Yeah. So anyways, so don't staple it's multiple papers together and expect to read through it really well. So anyways, well, thanks you guys. Fantastic stuff. Can't wait to talk soon. We're going to get Nick to publish his paper and see him present his results. And then I love this collaboration you're doing with the other institutions. I think that is something that we really need. Cool.
Appreciate it. Thanks for having us.
All right.
Thanks, guys.
Take care, fellas.
Thanks, guys.
Okay. Bye.
Thanks for listening to the Owens Recovery Science Podcast. Owens Recovery Science is a single source for PTs, OTs, ATCs, DCs, MDs, and other medical professionals seeking certification in personalized blood flow restriction rehabilitation training. Find them online at owensrecoveryscience.com.
One last thing before we get out of here. First, want to say a sincere thank you for listening all the way through, but also wanted to remind you that this podcast should not be considered medical advice. It is strictly entertainment. It's a way for us to try to keep up with what is ongoing within the BFR world. If you require some sort of medical attention, medical advice, please seek that from a licensed individual within your state. Thanks, and we'll talk to you soon.